Today, we're venturing into a world of incredible precision and really high stakes. The minimally invasive procedure known as endoscopic retrograde cholangiopancreatography, or
And
ERCP.
ERCP is. I mean, it's truly one of the most technical interventions in modern medicine, and its whole role has fundamentally changed.
How so?
Well, when it was first introduced, maybe back in the late 20th century, it was mainly a diagnostic tool, a way to just see the ducts.
Right.
But now, with less invasive imaging like MRCP and EUS, ERCP has become overwhelmingly therapeutic.
So when you're doing an ERCP today, you're not just looking.
You're not just looking, you're fixing.
And our mission for this deep dive is to really isolate the single most crucial and difficult hurdle in that fixing process: successful biliary cannulation.
That's it.
You are, in essence, trying to thread a tiny, flexible instrument into a microscopic opening deep inside the body.
And if you fail to get in, or worse, if you cause an injury while trying,
The whole procedure fails.
the procedure fails, or a severe complication follows. Precisely. And that difficulty is really why we're having this discussion. Just look at the variability in the outcomes. Failure rates for cannulation are cited to range from a low of 5% to an astonishing 49% in really complex cases.
Wow, 49%.
Yeah, and the average failure rate, even for very experienced endoscopists, it hovers around 20%.
So that variability proves that advanced strategies aren't just, optional.
They are mandatory for success and, critically, for safety.
It's amazing to think about the journey that got us here. I mean, it was only in the late 1960s that an obstetrician, McCune W., he provided the foundation for this.
Right. And then the real therapeutic shift moving from viewing to acting, that came when researchers at Erlangen and Kauai introduced the first biliary sphincterotomy,
They started cutting inside the body with a scope.
which was a total game changer. A leap of faith, honestly. It allowed clinicians to finally clear stones or place stents, and it turned ERCP from a sideline imaging procedure into a frontline therapeutic powerhouse.
So let's start at the beginning. If you're a patient, what's the most common reason you might find yourself needing this complex intervention today?
The list is pretty wide-ranging, but the most common things all involve some kind of blockage or disease of the bile duct.
Okay.
We're talking about managing common bile duct stones, something called cholangiopancreatography, treating infections like cholangitis, addressing strictures, maybe taking tissue samples for cancer.
And you can even do more advanced treatments now.
Yeah, like using radiofrequency ablation to treat malignant bile obstructions.
Now we have to talk architecture because everything hinges on one tiny anatomical gateway, the major duodenal papilla.
Also known as the ampulla of Vater. And you can think of it as the most critical intersection in the body's plumbing. This is the spot where the common bile duct, the CBD, which carries bile, and the pancreatic duct, which carries digestive enzymes, come together to drain into the duodenum.
And if they just came together neatly, I imagine it might be easy, but they don't, do they?
No, not at all. And that's the first layer of difficulty. They might merge into a short common channel, which makes it really easy to accidentally enter the wrong one.
I see.
Or they might join right at the orifice. Or, adding even more complexity, they can drain completely separately.
Which would make the target absolutely minuscule.
Exactly. The endoscopist has to navigate that really subtle internal geometry.
And to navigate that, you need specialized gear. ERCP uses a side-viewing duodenoscope.
Mhm.
Why that specific design?
Well, a standard forward-viewing scope would just overshoot the papilla. It's located right on the sidewall of the duodenum.
Ah, okay.
So the side-viewing design is essential. It allows the accessory channels, which are about 3.7 to 4.3 millimeters wide, to be brought up directly parallel to the papilla.
And then what are the tools you're actually using to get in?
The working tools are the cannulation catheters, usually between 5 and 7 French in diameter, though experts are increasingly favoring these ultra-tapered designs.
Like a 5F tapering down to a 3F.
Exactly, because that smaller tip allows for a more subtle engagement with that tiny orifice.
Hmm.
And then the guide system is the guide wire itself, which gives you visual confirmation under fluoroscopy that you are where you need to be.
Okay, let's get to the core technique. The patient is semi-prone, scope is positioned. What's the fundamental physical principle of entry?
The core principle is that biliary access has to be directed cephalad,
Meaning uphill.
straight uphill, relative to the position of the papilla on the duodenal wall. The endoscopist has to get perfect scope positioning and direct the accessory tip perpendicular to the orifice.
And why is that uphill angle so critical?
Because the common bile duct typically enters the duodenal wall at a superior oblique angle, If you try to go straight in, you'll just miss it completely, or worse, go straight into the pancreatic duct.
And you can't just force it in.
No, absolutely not. The endoscopist has to use a very specific touch, what we call insinuation.
Insinuation.
It means gently advancing the accessory tip, just to achieve a secure seating, making sure the anatomy isn't distorted or pushed away. Forceful engagement is the road to failure.
Okay, so avoiding distortion, aiming uphill and sideways. It demands incredible dexterity. But now we have to talk about the dangers of the journey. The biggest threat, the one that dictates so much of the technique, is post-ERCP pancreatitis.
PP.
PP is the outcome every endoscopist absolutely dreads. It is the most serious complication, and while incidence is usually low, it can climb as high as 30% in high-risk groups.
And minimizing that risk informs every single choice you make.
Every single one.
Which brings us to the gold standard technique, wire-guided cannulation, or WGC. The European Society of Gastrointestinal Endoscopy, ESGE, recommends it for primary cannulation.
They do, and it's explicitly contrasted with the older contrast-assisted cannulation.
So why is contrast the very thing that helps you see such a risk here? Well, the old method relies on injecting contrast to visualize the ducts. The problem is, if you inject into the wrong duct, the pancreatic duct, you can cause opacification.
Right.
And the resulting hydrostatic pressure, plus the chemical irritation of the contrast itself, can trigger that dangerous inflammatory response we call pancreatitis.
So WGC flips the priority. You use the soft wire to confirm your path first, and only then do you inject contrast.
Exactly. The meta-analyses are very clear on this. WGC is superior. It significantly increases the rate of successful biliary cannulation and is consistently associated with a lower risk of PAPP. The wire acts as a gentle, low-pressure guide rail.
So if WGC is so much safer and better, is there any reason to still use contrast-assisted cannulation?
In high-volume centers, WGC is truly the default. You might see contrast used if you just need rapid visualization in a non-high-risk case, or maybe if the wire just won't advance and you need a tiny puff of contrast to check the angle.
But even then,
the priority is minimal injection. The data is clear. The risk profile just shifts dramatically with contrast injection.
that distinction is so important. Now let's define failure. Since persistence is key, but safety demands restraint, when do you formally declare a case is difficult?
This is probably the most important threshold in the entire procedure.
Yeah.
ESGE has a definition for difficult biliary cannulation.
The 5-5-1 rule.
The 5 attempts, 5 minutes, 1 PD cannulation rule. That means if you've tried to cannulate 5 or more times over 5 minutes, or if you've inadvertently cannulated or opacified the pancreatic duct multiple times, you must stop and escalate your strategy.
That's a tight threshold. It forces the team to switch from sort of hopeful technique to decisive intervention very, very quickly.
It has to be.
And briefly, before we get to escalation, how much does patient cooperation matter?
Stability is everything. These procedures require the patient to stay completely still, often in that semi-prone position, which means deep sedation. We're seeing studies favoring propofol and dexmedetomidine protocols, ProDex, because they often lead to faster sedation and shorter recovery. Optimizing patient stability directly translates to the endoscopist's ability to perform that delicate insinuation.
Okay, we've established the technique, the time limit. Now we face the real enemies, the anatomical roadblocks. What is the endoscopist seeing that physically stops them?
The anatomy is the great variable. The morphology of the major duodenal papilla itself is the #1 challenge. If the papilla is small, or if it's a protruding type 3 papilla, or famously what's known as the Sharpay papilla.
A Sharpay papilla, you mean like the dog with the redundant folds of skin?
Exactly. It has these redundant floppy folds of tissue that just obscure the orifice.
So they flop around and hide the entrance.
They do, and it makes it nearly impossible to hold the accessory tip steady.
And it's not just the entrance, it's the location too, right? A papilla positioned too far down or oriented the wrong way must throw off that critical cephalid angle.
It does. But the most disruptive element, by far, is the presence of periampullary diverticula, or PAIDs.
These are small pouches or pockets located right near the papilla.
Right, and they completely change the game.
How so?
They distort the entire landscape. PAs displace the anatomical landmarks, forcing the endoscopist to completely abandon that standard uphill angulation. Sometimes the bile duct enters almost horizontally because the entire structure has been pulled aside by the diverticulum.
So you might even have to manipulate the diverticulum itself just to see the target.
You might have to gently press on the rim of the diverticulum just to expose the papilla, which, as you can imagine, carries its own small risk of perforation.
And beyond the local anatomy, what patient factors signal a higher difficulty?
Well, aside from the anatomy, we know that endoscopist experience is a huge predictor. Low-volume centers have more failures.
And for the patient themselves?
Patient factors include female gender and underlying conditions like pancreatic cancer, where the disease infiltration into the papilla just makes the tissue friable and prone to bleeding.
What about altered surgical anatomy? Like a Billroth II or a Roux-en-Y reconstruction. That sounds like a technical nightmare just to get to the right spot.
It absolutely is. You're working against gravity, against rerouted intestines. These cases require specialized equipment, primarily balloon-assisted enteroscopy, just to navigate the altered loops and reach the target.
But it can be done.
Oh, yeah. The good news is that for those specific, highly difficult access cases, expert use of balloon enteroscopy has a very high success rate, around 95%.
So we've hit the 5-5-1 rule. The standard WGC uphill approach has failed. The team pivots. If standard techniques get you, 87% success? What kind of boost are we getting from these advanced salvage techniques?
We're talking about pushing that success rate way up into the high 90s, often cited as high as 98.3%. This is the procedural art, deciding exactly how to breach the papilla safely.
Let's start with the pre-cut methods, or access sphincterotomy. This is where you intentionally make an incision to expose the orifice.
Correct. The incision is made in the 11 o'clock direction, typically with an electrosurgical cutting wire or a needle knife.
And the ESGE has recommendations about the type of electrical current, right?
Yes, this is critical. The ESGE recommends using a mixed current over a pure cut current.
Can you explain the difference for someone listening? What's the functional difference between pure cut and mixed?
A pure cut current is exactly what it sounds like. It just slices cleanly, but it offers no coagulation.
Oh, blood clotting.
Right. A mixed current incorporates coagulation energy. So by using mixed current, you are simultaneously cutting and sealing the smaller blood vessels, which significantly mitigates the risk of immediate bleeding. It's just a safer, more controlled way to open the tissue.
And within pre-cutting, there's a technique called fistulotomy. What's the distinction there?
Fistulotomy is a specific type of pre-cut where the incision is made directly on the dome of the ampulla, the ceiling of the opening, and you cut upwards until you see bile drainage.
And this isn't for everyone.
No. ESGE is clear that needle knife fistulotomy is the preferred pre-cutting method, but, and this is a big but, it should only be performed by endoscopists who already have a high standard cannulation success rate, over 80%. It is strictly an expert maneuver.
The sources also mention stent-guided pre-cutting. That sounds like a protection-first approach.
It's a phenomenal protective measure, especially in high-risk patients. If you keep accidentally entering the pancreatic duct, you can intentionally place a small, short prophylactic pancreatic stent.
Usually 3F or 4F size.
Right. And that stent does two things. It acts as a clear landmark for your cutting device. And, most importantly, it acts as a protective drain, ensuring pancreatic juice can flow freely during and after the incision.
Which drastically reduces the PAP risk from the procedure.
Drastically.
Now, let's talk about the double wire maneuver. This is fascinating because it seems so counterintuitive. You're intentionally cannulating the duct you're trying to avoid.
That's the psychological pivot of the technique. When your guide wire repeatedly slips into the pancreatic duct, you just intentionally leave a soft-tipped wire deep inside that duct.
And what does that do?
The presence of that wire physically straightens out the often tortuous intraampullary angles of the common channel.
Ah.
This straightening effect makes it mechanically easier for a second wire, loaded in a separate cannula, to be advanced alongside the first and successfully into the biliary system.
That is surgically elegant, but since you're intentionally manipulating the pancreas, the risk of PK must be huge.
It's highly effective, but because you have two instruments in the ampulla, and one is deep in the pancreatic duct, prophylactic pancreatic stenting is not just recommended.
It's mandatory.
It is mandatory for the double wire maneuver to mitigate that spike in post-ERCP pancreatitis risk.
And finally, which advanced technique, when performed by an expert, yields the highest success rate of all?
That would be the transpancreatic sphincterotomy. This involves cutting through the septum, the dividing wall between the biliary and pancreatic ducts.
You're just creating a new direct channel.
A wide direct channel into the common bile duct. And just like the double wire technique, it has to be done by experts and is always followed by prophylactic stenting.
So what happens when the endoscopist has exhausted all of these complex internal strategies and still can't get biliary access?
Then we move to the highly effective rendezvous methods.
Okay.
These methods rely on accessing the ducts from the outside and using that access to guide the instruments internally. The two main paths are EUS-guided and percutaneous.
EUS-guided rendezvous, or EUSRV, uses real-time ultrasound imaging.
Yes, the endoscopist, guided by the EUS image, uses a fine-gauge needle to puncture the ducts. They then pass a guide wire antegrade meaning forward, straight through the duct and across the papilla.
So the wire ends up dangling out of the duodenal orifice.
Exactly. Then the conventional duodenoscope can just grab it and complete the rest of the procedure normally. It acts like a temporary custom-made path.
That sounds incredibly precise, and the alternative is the percutaneous approach.
That usually involves interventional radiology. They access the biliary system transhepatically through the skin and liver and then pass the guide wire antegrade. This route is typically reserved for the most technically demanding cases, and it boasts a remarkable 96% technical success rate.
We've focused a lot on PEP, but we have to mention perforation. It's rare, less than 1%, but it's catastrophic when it happens. How do you classify that kind of injury?
Perforation is very serious, and its classification really dictates the management. We use the Stapfer classification, which breaks down the injury based on location and mechanism.
And how does that help determine whether the patient needs surgery?
Well, a type 1 is a duodenal wall perforation, often from the scope itself. A type 2 is periampullary, usually from the sphincterotomy. These can often be managed non-surgically.
And types 3 and 4?
Type 3 is a perforation deep in the bile duct from an instrument, and type 4 is the mildest. It's usually just retroperitoneal free air, often from a guide wire, and it can frequently be managed medically with just observation. Knowing the type dictates everything.
Finally, let's wrap up this deep dive with the future. How is artificial intelligence influencing a procedure that demands such high human expertise?
AI, specifically deep learning models like convolutional neural networks or CNNs, is emerging as a critical aid.
In what way?
These systems are being trained to automate the immediate detection of the ampulla and, crucially, to predict the difficulty of the cannulation before the first attempt is even made.
So the AI could look at the image of the papilla and say, warning, this looks like a Sharpie papilla, or this has a high predictive score for hitting the 551 rule quickly.
Exactly. And this capacity to predict difficulty allows the endoscopist to completely streamline their decision-making. If AI flags a case as high risk, they can immediately prepare for or even start with an advanced technique.
So you could skip those initial frustrating minutes of standard attempts.
Saving time, minimizing papillary trauma, and ultimately reducing the likelihood of adverse events.
So what does this all mean for the clinician and for you, the learner?
The synthesis is this. Achieving successful ERCP is the ultimate balance between technical finesse and strict safety adherence. Mastering the basics, like WGC, is foundational.
But it's not enough.
Not at all. True expertise lies in recognizing the anatomical roadblocks like pétades or complex papillary morphology, and knowing precisely when and how to transition to advanced salvage maneuvers, all while adhering to the guidelines on prophylactic stenting.
The goal is always success.
But the priority is always minimizing injury.
That procedural tension is incredible. Success demands persistence. But the safety data, especially for PP, demands immediate restraint and rigid adherence to those strategic limits. That 5-minute rule.
The endoscopist is walking a very, very fine line.
And as we look to the future, with AI systems becoming highly accurate at predicting procedural difficulty, we're left with a provocative thought. If an AI can reliably predict, within seconds, that you will fail the 551 rule, how will that precision alter the endoscopist's decision-making timeline? Will intervention become earlier and more aggressive, focusing immediately on pre-cutting? Or will it allow for a more precisely restrained and optimized approach from the very start?